Dr. Maheshwaren K.
I am going to present a rare case of abductive palsy due to fungal sinusitis with the cavernous sinus involvement. 39-year-old male present with complaints of binocular double vision for 1 day with horizontal separation of images, more on left lateral gaze. There was no history of trauma, defective vision, nausea, vomiting, and no history of previous surgeries. There was no relevant past history. He's a known diabetic for 2 years and is a known alcoholic for 6 years. In general examination, he was conscious oriented, moderately built and well nourished, and systemic examinations were normal. His vitals were stable, and the random blood sugar was 227 mg per deciliter, HbA1c 10.4%. On ocular examination, his right eye best corrected visual acuity was 6.9, and in investigation, intraocular pressure by non-contact tonometry 70 mm mercury, and his color vision was normal. In left eye best corrected visual acuity 612 partial, intraocular pressure by non-contact tonometry 40 mm mercury, color vision was normal. In anterior examination, he had both a posterior polar cataract. In paratic squint evaluation, he had a small angle esotropia in left eye. In cover test, he had alternate esotropia with the right eye dominance. In extraocular examination, he had a left eye obstruction restriction present. Able to appreciate the left eye obstruction restriction, left eye levo elevation restriction, levo depression restriction. In posterior segment examination, everything was within normal limit. So ordered a MRI with MRI brain. In T1 weighted post contrast, in axial view, we can able to appreciate the ethmoidal sinusitis. In coronal view, we can appreciate the macular sinusitis. In sagittal view, we can able to note the sphenoidal sinusitis. In coronal view, there was a cavernous sinus involvement noted. So based on the MRI with MRI, there was a semi-invasive fungal sinusitis with involvement of right macular artery, both ethmoidal and sphenoid sinus, and minimal left cavernous sinus extension. So the diagnosis was sixth cranial nerve palsy due to invasive fungal sinusitis with the cavernous sinus extension with both a posterior polar cataract. Patient was referred to ENT surgeon. Then he underwent functional endoscopic sinus surgery. There was a complete resolution after within 1 week of surgery. And discussion. Abductive nerve palsy is the most common cranial nerve palsy. Due to its long intracranial course and its dual attachment to the skull base, it is more vulnerable to variable inserts. Etiologies are hypertension, diabetes, trauma, multiple sclerosis, neoplasm, cerebrovascular accident, post-neurosurgery. In my case, diabetes is a known case of diabetes, most probably due to the immunocompromised state. Clinical features are symptoms are binocular diplopia with horizontal separation of images, more on lateral gaze. Signs are abduction restriction, uncrossed diplopia, first face turned towards the side of diplopia. Treatment like in antifungal medications, broad spectrum antibiotic medication, surgical intervention to decompress any space occupying debris and purulence. In prognosis for lesions like benign and non-invasive lesions leads to a complete resolution. In case of lesions which invading the nerve and its blood supply, it leads to partial or no resolutions only. A similar case reported by W.S. Leong, sixth nerve cranial palsy, secondary sphenoidal sinusitis, treated with endoscopic transnasal sphenoidectomy. Patient was recovered completely after 3 months. There is another case reported by L. Theoris et al. Reported a case of sixth nerve palsy due to sphenoidal sinusitis. In patient was treated with endoscopic transnasal sphenoidectomy. Intraoperatively, they visualized larger fungal ball in the sphenoid sinus. Patient was completely recovered 4 days after surgery. These are my references. So sixth cranial, it is a rare case but treatable. Early treatment with appropriate medical management, surgical decompression, it lead to excellent prognosis. Patients with history of diabetes with comes with a sudden onset of diplopia, we should rule out infections like sinusitis also.
Was the patient on insulin?
No, sir. On oral OHA only.
Only OHA. And what about that your cavernous sinus? What happened to that lesion? Because it was the extension into the cavernous sinus also.
Yes, sir.
Because you mentioned that 1 week after the surgery, I think sphenoid endoscopic sphenoid clearance was done, na?
Yeah, they did functional endoscopic sinus surgery, sir. Followed that they amputosum B and taxim also given.
So how did you rule out all the other cranial nerves, because it's so close to cavernous sinus, no?
So the anterior part of the cavernous sinus was involved, no? It was anterior or whole of the cavernous sinus? The mid and the posterior. So you have shown only one cornal section.
Yes, sir. Based on the contrast.
No, which part of the cavernous sinus? It was only anterior part, because the madam has asked regarding the other cranial nerve, because it is cavernous sinus.
Yes.
Definitely the other cranial nerves.
So
Must
6
have
nerve in
been-
the medial wall. So most proximal to the paranasal sinus. There is a minimal invasion, so probability to the medial walls.
So
There is
what-
no definition of minimal invasion, na?
What examinations did you do to rule out the other cranial nerves?
It for I checked for the taste sensation, ma'am.
Which sensation?
I checked taste sensation.
No, the ones which
No.
are near cavernous sinus, no? How did you check that?
Sorry.
What about the V1 and V2?
I checked for ocular sensation also.
Corneal sensation.
Corneal
so-
sensation.
Only corneal sensations. The V2 area was not checked. Everything was okay till the cavernous sinus is involved, na? That is the reason we are asking. Okay, thank you.